Today we explore a truly paradoxical medical case, a young man diagnosed with complex regional pain syndrome, or CRPS, but without the hallmark symptom, pain. This rare presentation challenges our understanding of CRPS and highlights the importance of considering atypical cases in clinical practice. As we walk through this story, you'll see how careful observation and advanced diagnostics led to a surprising conclusion. Let's begin by understanding what makes this case so unique and why it matters for both doctors and patients. Story centers on a 32-year-old male who visited the outpatient department with a slow progression of symptoms. He reported weakness in his foot, abnormal posture, swelling, and changes in skin temperature and color. What stood out was the complete absence of pain, which is typically a defining feature of CRPS. Despite extensive testing, no clear cause for his symptoms was found. This left doctors with a diagnostic puzzle. Could this really be CRPS without pain? Complex regional pain syndrome, or CRPS, is a rare condition that usually develops after an injury. It's characterized by severe, persistent pain that's out of proportion to the original trauma, along with changes in skin color, temperature, swelling, and abnormal sweating. CRPS can affect any part of the body, but most often involves the limbs. The condition is rare, affecting only a small fraction of the population, and is more common in women and people aged 40 to 50. CRPS is notorious for its intense, burning pain, but it also brings a host of other symptoms. Patients may experience sensory abnormalities, such as heightened sensitivity to touch, as well as changes in skin color and temperature. Swelling, abnormal hair and nail growth, and muscle weakness are also common. These symptoms can make daily life extremely challenging, both physically and emotionally. There are two main types of CRPS. Type 1, the more common form, is usually triggered by soft tissue trauma without direct nerve injury. Type 2, on the other hand, is linked to a specific nerve injury. Despite these differences, both types share similar symptoms and are treated in much the same way. Interestingly, some cases have been reported where CRPS develops without any obvious trauma at all. Exact cause of CRPS remains a mystery. Experts believe it involves a complex interplay between the central and peripheral nervous systems. Abnormal inflammatory responses, nerve sensitization, and even autoimmune and psychological factors may all play a role. This complexity makes CRPS difficult to diagnose and treat, especially when symptoms don't follow the usual pattern. In this case, the patient's symptoms began after a traumatic event, a military injury involving an anti-tank mine explosion. Remarkably, there was no shrapnel or penetrating trauma, and he initially showed no neurological or vascular problems, but within weeks, he developed progressive weakness and sensory changes in his left foot, along with persistent coldness and skin discoloration. Still, he felt no pain. In examination, the patient's left leg was colder and slightly weaker than the right. The foot was swollen and discolored, turning cyanotic when he sat with both feet on the floor. His gait was abnormal, and he needed a cane for balance. Despite these clear signs of dysfunction, he reported no pain at any point during his illness. Diagnosing CRPS is never straightforward, but this case was especially challenging. The Budapest criteria, the gold standard for CRPS diagnosis, require ongoing pain as a prerequisite. Since the patient had no pain, doctors had to rule out other possible causes, such as central nervous system disorders, nerve damage, and vascular insufficiency. A battery of tests was ordered to search for answers. Imaging studies, including MRI and CT angiography, revealed some abnormalities. The MRI showed fatty infiltration in the left calf muscles, while CT angiography detected an occlusion in the dorsal foot artery. Isotope angiography and bone scans indicated inflammatory changes and microcirculation problems, but no bone destruction. These findings pointed to a complex process affecting both nerves and blood vessels. Electrodiagnostic tests, such as nerve conduction studies, NCS, and electromyography, EMG, were performed to assess nerve function. The results were mostly normal, except for a mild increase in distal latencies due to the lower temperature of the affected leg. No evidence of nerve degeneration or demyelination was found, further complicating the diagnostic picture. Other neurophysiological assessments included motor evoked potentials, MEPs, and somatosensory evoked potentials, SSEPs. These tests confirmed that both central and peripheral nerve pathways were intact. The results helped rule out central nervous system lesions and supported the exclusion of other neuropathies or spinal cord injuries. Given the patient's vasomotor symptoms, vascular studies were crucial. Doppler ultrasound and isotope angiography were used to assess blood flow and microcirculation. These tests revealed microvascular dysfunction and autonomic dysregulation, which are often seen in CRPS. The integration of neurophysiological and vascular data was key to narrowing down the diagnosis. Initially, the patient tried self-prescribed supplements, neuromuscular electrical stimulation, and acupuncture, but none of these provided relief. After 3 months, he was admitted to a specialized clinic for further evaluation. Despite the lack of improvement, he remained free of pain, which continued to puzzle his medical team. Thorough neurological assessment revealed muscle weakness in the left foot, with absent ankle reflexes on that side. However, the patient was alert, oriented, and had normal speech. His symptoms included vasomotor, trophic, pseudomotor, and motor disturbances, all objectively confirmed, yet pain was still completely absent. Budapest criteria are the gold standard for diagnosing CRPS. They require continuing pain, sensory changes, vasomotor symptoms, and motor or trophic changes. In this case, all criteria were met except for pain. This raised the question, can CRPS exist without pain, or is this a different condition altogether? Reach a diagnosis, doctors had to exclude other possible causes. They considered central nervous system disorders, radiculopathy, peripheral nerve damage, and vascular insufficiency. Only after ruling out these conditions could they settle on a diagnosis of CRPS, despite the lack of pain. Summary of imaging and electrodiagnostic studies showed no abnormalities in nerve ultrasound or vascular ultrasound. MRI of the brain was normal, and MRI of the lumbar spine showed a minor disc protrusion without nerve compression. The only notable findings were fatty infiltration in the calf muscles and a dorsal foot artery occlusion. Patient was discharged without improvement, but was prescribed physical therapy and an ankle-foot orthosis. These interventions significantly improved his gait and foot positioning and also had a positive effect on his emotional well-being. Long-term psychotherapy was also recommended to support his recovery. This case is not entirely unique. Several reports in the medical literature describe CRPS-like syndromes without pain. Some researchers have even proposed a new term, complex regional painless syndrome, or CRPLS, to describe these cases. However, the underlying mechanisms remain poorly understood. Studies have found that a small percentage of CRPS patients do not experience pain. For example, a 1993 study of over 800 patients found that about 7% had no pain, though most still had other classic symptoms. Other case reports have described similar findings, often following trauma or surgery. Some researchers suggest that abnormal nerve sensitization, changes in blood flow, and lack of proprioception may contribute to CRPS-like symptoms without pain. Others point to the role of immune system factors, such as cytokines and autoantibodies, in driving the disease process. Recent research has proposed dividing CRPS into subtypes based on the predominance of certain symptoms. Some patients have mainly vasomotor and motor changes, while others have more pain and sensory symptoms. A third group shows a mix of all categories. This approach may help explain why some patients, like ours, do not experience pain. There is no single test for CRPS. Diagnosis relies on clinical criteria and the exclusion of other conditions. Various diagnostic algorithms recommend a combination of imaging, nerve studies, and laboratory tests to rule out other causes and confirm the diagnosis. The goal is to identify CRPS early and start treatment as soon as possible. Emerging research is exploring the use of biomarkers such as cytokines and immune cells to aid in the diagnosis and prognosis of CRPS. These markers could help identify atypical cases and improve our understanding of the disease's underlying mechanisms. Treatment for CRPS focuses on managing pain and other symptoms. Physical therapy, occupational therapy, and psychological support are the mainstays of care. While pain management is often challenging, there are fewer options for treating vasomotor and pseudomotor symptoms, which can be just as debilitating. With ongoing physical therapy and the use of an ankle-foot orthosis, the patient's mobility and emotional well-being improved. This highlights the importance of a multidisciplinary approach, even when pain is not present. Supportive care can make a significant difference in quality of life. Despite advances in our understanding of CRPS, many questions remain. Why do some patients develop CRPS without pain? What are the best ways to diagnose and treat these atypical cases? More research is needed to unravel the mysteries of this complex condition and improve outcomes for all patients. This case reminds clinicians to keep an open mind when evaluating patients with unusual symptoms. CRPS should be considered in the differential diagnosis even when pain is absent, especially if other classic features are present. Early recognition and intervention can help prevent long-term disability. In summary, CRPS is a rare and complex disorder that can sometimes present without pain. This paradoxical case challenges traditional diagnostic criteria and underscores the need for comprehensive evaluation. By staying alert to atypical presentations, healthcare providers can offer better care and support for those affected by this mysterious condition.